Okay, so let's do a quick example here, at least combining it all together with the G and the T pal. So this is the history that we see in the chart. We've got a 48-year-old expecting triplets. Has 3 children. Let me do it this way. So she has 3 sons who were all born Okay, so this is what we know. What would her GTPAL or GTPAL be? "48-year-old expecting mom. She's expecting triplets. She has 3 sons, and they were all born at 32 weeks. And she's got a set of twin daughters born at 40 weeks." So we're going to do GTPAL. We're going to do gravidity and the TPAL all together. So GTPAL. So let's see. So for your TPAL, did we say T1, P3, A, P3 to 4, A, G3, T1, P1, A0, L5? Okay, let's see. So for the gravidity, no problem. No problem at all. So for the gravidity, she's currently expecting, so that's 1. And she's delivered, or she's been pregnant before because she has 3 sons who were born at 32 weeks, and she has a set of twin daughters. So that would be G3. And then for the term, how many were born term? Only that set of twin daughters because they were born at 40 weeks. So the T1 checks out. Now for the preemies, how many preemies? Well, these three sons, they were all born at 32 weeks. So the way that this is written here, we're going to say that this had to have been a set of triplets that were born at 32 weeks, because it says they were all born at 32 weeks. And that would be the one for preterm. Even though it was three of them, it's still just one. And then for abortus, there was nothing mentioned about losing any babies. And then for the living, now we get to count them all up. And she's got the three sons and the two daughters that are still living. So then that's our 5. So good job, Fareshta. Let's see, I got a question here. How do we know that the sons were triplets? They could have been, but the way that this is written, they were all born at 32 weeks. Now, it could have been that they were individually born, and each one was born at 32 weeks. But the way that it's just presented here, it just looks like they were born as triplets. Right, we should not assume, but that's what I meant by making these tough calls and making these kind of decisions. Now, if it was specifically written out that one son was born at 32 weeks, another son was born at, say, 38 weeks, and another son was born at, now that for sure, we're looking at individual. But they're just kind of grouped together, like they're all born at 32 weeks. So then that would lead us to believe that we're saying that this is a set of triplets here. So you're right, we really shouldn't have to assume, but again, given just this little bit of information, and I did it on purpose because that's what they do a lot of times, is they just kind of leave it up to you to say, are we really talking about specific individual children here? Or are we talking about multiple gestation? And again, another thing that would lead you to believe that these were probably triplets is it may seem like they don't have anything to do with the other, but she's currently expecting triplets. She has daughters who are twins. So it just kind of looks like she's always had multiple gestations. And that's a risk, it's like always a high risk factor. And she's got, and she's over age of 40. So that's also another risk factor. Now, she hasn't reached grand multiparity or anything like that, or grand multigravida. But again, with everything else that's going on, then this will be a possible concern, which means that you might need to be called because she may have to end up having a C-section. Or she may start delivering naturally, and then something happens, either in the middle of delivery and they have to call you to the birthing room, or right after delivery, then the babies aren't doing that well, then they'll end up calling you. So it's kind of like a rapid response in a sense, except it's not a rapid response. It's just you're the delivery team, and they're going to reach out to you to come and take a look at what's going on and see what needs to be done. Okay. All right, so again, take a look at the video if you're still not really sure what's going on, because of the way the nurse will explain it, then you should be able to follow along with it a whole lot easier. She's at a whiteboard and she's got all that stuff on the whiteboard, and that'll probably help a lot. Okay. So now we continue on with some of the things that would be red flags as far as this will possibly be a complicated delivery. And we look at now what's going on as far as like with the placenta or with the amniotic sac or the amniotic fluid or something of that nature. So we say that the amniotic fluid, for all intents and purposes, is supposed to be sterile, which is why anytime that her water breaks really, really early on, so the premature rupture of the membranes, which is again just water breaking, If that happens, then there's always a chance that the baby's going to end up infected with probably like the GBS, or it could be something else that mom has been identified as being infected with. And then not only is the infection our concern, but what about just the cord itself? So while the fluid is inside, or while the baby's inside the amniotic sac, and there's a lot of fluid surrounding him, this is what's kind of helping to keep the cord from moving around or ending up in the wrong place. So without any fluid, this cord could end up drooping. It could end up falling way down here, and then that could be a problem if she's like in the middle of like she's in the middle of birthing. All right, now, so they're saying almost half of the preemies that are born is because the water broke really early on. And there's not much you can do. I mean, there's no way you could fix that. Now, what I was saying earlier, either you or your partner on the delivery team is going to have to check to make sure that the vessels are there like they're supposed to be after the cord has been cut. So you're just literally just feeling you're feeling around on the stump and checking to make sure that there's two arteries and one vein. And it should be pretty obvious because the vein is going to be like really big and floppy, and then the arteries are a little bit smaller. So let's say that there's only one of each, your one vein and then only one artery, then that could have been the reason why the baby was born really small. And then a shorter cord, that could mean that as she's in the middle of delivery, as she's doing like a natural delivery, that short cord could literally end up causing what they call the uterine inversion. It could just pull the uterus inside out. And we know that that's not going to work out. And then if the cord is too long, then it really ends up sometimes just wrapping around the baby's neck. And you have to document that. Like say if you're on delivery and they're doing like a C-section, as the OB takes the baby out, they're going to have to quickly unwrap the cord from around the baby's neck, and they'll tell you how many times that cord was wrapped. So they'll say, oh, you got a cord wrapping times 4. So it meant they had to like literally like unwrap or unravel, and that could have meant that your baby was going to have some problems. Not always, but it still has to be recorded, because anytime that something happens later on with the baby, then you can start kind of like tracing back to some of the events that happened. Like, well, cord was wrapped around the neck, or this was going on and this was happening, and et cetera, et cetera. And just remember that the baby when he has room, that is, when there's room, he's moving around a lot. And that cord, even though the fluid is kind of helping to keep it suspended, it still will a lot of times end up, again, getting in knots and wrapping around the neck. Okay, so then this is like the whole, like the umbilical cord prolapse situation that could happen, especially if the membranes rupture before they're supposed to. And then on the left here is just like what you would be looking for. And it kind of like looks like nothing, but if you were there in person and you were holding this, you could probably determine that this has got to be the vein and these have got to be the arteries here. Placental abruption. Sometimes they'll refer to this as abruptio without the N on the end of the word. It all means the same thing. It just means that, of course, the placenta is no longer completely attached to the wall of the uterine wall. And anytime this happens, you got to remember that the whole point of having that placenta is so that there's going to be the connection between the baby and mom as far as blood supply. And any separation is going to mean that you're compromising the blood flow. And if there's a compromise in blood flow, then it means that there's always a chance of the fetus having asphyxia in utero. And we'll talk about the different stages of asphyxia, or just say we'll talk about like primary versus secondary apnea. And then if there's a lot of separation going on, then that means that, of course, the mom could risk the bleeding. And then placenta previa. Previa, this is the example they gave us here is like the worst case scenario. This is usually not a problem if it's considered like a partial previa, meaning that maybe the placenta ended up moving, or maybe it just ended up attaching, maybe here, maybe pretty close to the opening, to the actual cervical opening. Maybe it's kind of close there. And if it did happen, it usually will be identified early on, like maybe going like around the second trimester. And then by the third trimester, everything has already been shifting. Everything is now shifted. The baby is upside down because that's going to probably be the most area that he's got in the womb. It's going to be at the bottom of the womb versus the top. So with all this shifting and everything that's going on, a partial type of placenta previa is not necessarily a problem. But in this case, this is a complete previa, meaning that, as you see, that uterus, not a uterus, that the placenta is literally covering the cervical opening. And again, if this wasn't recognized beforehand, if it wasn't identified beforehand, then if she's now in the midst of delivering and she's doing it naturally, then that could cause a huge amount of hemorrhaging, a huge amount of hemorrhaging. And if they realize that this is the case, then this is going to be an automatic schedule C-section, because it's just too risky. And it wouldn't make sense to try to deliver normally or try to deliver naturally like this. Now, the actual fluid itself, the amniotic fluid, now, there's a lot going on with there. First of all, it starts with the mom. The mom's blood, or actually the plasma. Her plasma is what's going to contribute to this amniotic fluid, mostly. And then the rest of it is going to be the baby urinating, and also a little bit of that fetal lung fluid as well. And then also the baby's, as I say, the baby's periderm is going to help contribute to that fluid volume as well. Now, the whole thing about fetal lung fluid, as long as the baby is actively swallowing or like doing his practice breathing, then that's going to help to ensure that there's a balance between what's being produced and what's being eliminated. And the same goes for the overall amniotic fluid in general. So if the baby's got some kind of swallowing problem, like for whatever reason, he or she's just not really able to swallow the fluid, then that would mean that your balance is now going to be off. You're going to end up with a lot more of this fluid compared to normal. So then that would be considered polyhydramnios. And then if something else is wrong with the baby wasn't really able to produce the necessary fetal lung fluid, the baby wasn't really producing a lot of urine and things of that nature, then you're going to end up with too little fluid. And that would be, of course, oligohydramnios. And there's another comment I guess I want to make is polyhydramnios could be more than just some kind of swallowing problem. It could be gestational diabetes because with the baby now receiving all this extra glucose from the mom and then having to produce all this insulin to deal with it, that's also going to generate a lot of urine production. And the extra urine is something that could kind of like maybe tip off the OB that, well, we got a lot of fluid, so they can detect like how much fluid there is, like from ultrasound. There's a lot of extra fluid here. And then they'll have to start looking into things like, have to do like a fasting blood sugar kind of test to see what's going on with mom. Is it that maybe she's developed gestational diabetes? And then any preterm birth. We say that any birth less than 37 weeks is preterm. So the younger, the more risk for the baby is as we know. And if you're born extremely early, this is just a general rule. It's not in stone, but let's say that you were born at 32 weeks. You're probably going to be in the hospital. You're going to probably be in that nursery for about the amount of time that you should have still been in utero. And that's how it sometimes works out, but not always. Sometimes they get to leave earlier because they start to improve. They respond to the therapy and then they pick up weight and they're fine. And at other times they may be so small and so premature that you're going to have to, of course, place them on the ventilator, and then that really gets complicated. So once you place them on a ventilator, then they're going to be at risk of developing like BPD, for instance, or bronchopulmonary dysplasia, and then that could extend their stay in the nursery. But either way, the younger you are, the more at risk you're going to be for a lot of problems. And especially like the brain bleeding, the IVH here, as they call it for short, this will be graded. This will be like grade 1, 2, 3, or 4. And again, the younger you are and the smaller you are, we're thinking like micropreemie territory, they usually have the worst brain bleeding. They will have like a grade 4. And again, that's just going to be extremely difficult to treat in some cases because not only is all their systems just really immature and haven't had a chance to develop yet, but now they're outside and you've got to now somehow find a way to minimize all of that stuff that's going on the outside, like all of the noise and any stimulation. You're going to have to somehow manage it so that it's going to and it's going to help this baby continue to develop and grow. And that's easier said than done when you're dealing with a hospital setting. No matter how quiet you try to keep that environment, there's stuff going on all the time. There's alarms going off. There's people talking. There's traffic. There's a lot of things going on. And that just works against these poor preemies in a lot of cases. Now, how do they diagnose a preterm birth? So, 6 contractions in an hour, and there's been proper effacement of the cervix. Now, if it's way too early and the baby is trying to be delivered, then they'll have to try to do something. They'll have to try to like slow this process down. And what they could do is they could give some type of tocolytic. Tocolytic is is basically like bronchodilators. I mean, they're going to target the smooth muscle of the uterine wall, and they're going to cause the muscles to relax, and so that should combat the contraction. Like there's like this active contraction that's going on, and again, this baby is just far too young to be delivered right now, or if he does get delivered, he's going to have a hard time. So they'll give some kind of tocolytic, and they can also give steroids. Now, the steroids are going to be given to the mom, of course. And what that'll do is the steroids are going to easily cross over from the placenta to the baby. And then that's going to help to accelerate the surfactant process as far as to get it closer to that ratio, that 2-to-1, quicker. And then let's say you've got a little one who's trying to be born, who has no business being born that early. This is something they could also do. They could go in and surgically do what's called a cerclage. And in this example, they're using like a band to essentially kind of like block the passageway. So you're encircling the cervix so that that way, as the as the uterus is contracting and et cetera, then that's gonna kind of act as at least a keep the baby in, and that way he'll get a chance to hopefully stay in long enough to mature a little bit more. Okay. Oh, it's lunchtime. Yeah, so let's go ahead and take our lunch. I think we're still making good progress here. I think we'll be okay and get through everything today. So it's 11:50, so we'll be back from lunch at 12:40.